The urinary system, comprised of the kidneys, ureters, bladder, and urethra, is really a fantastic system. Very simply put, its job is to clean the blood and to make sure that the blood composition is what it needs to be. But it's a lot more complicated than you would think that it might be just to achieve that. So every day, the kidneys filter about 47 gallons of fluid out of the blood. But if you think for a second, you would realize that we don't have 47 gallons of fluid in our body to start with. So what this means is that of that 47 gallons, most of that is going to be returned to the bloodstream again. So it turns out that the kidneys consume a tremendous amount of energy because they're filtering out this 47 gallons and putting all but about 1.5 quarts back into the blood again. So there's a lot of energy expended taking things out that ends up being put right back into the system. But that's just how it works. So we have to roll with that. What we see here is a glomerulus, and we'll see that a little bit closer up here in a little bit. This is just a really fabulous picture of what the inside of one of those filtering units would look like. If we look at the orientation for where everything is, we find the kidneys high in the abdominal cavity to the back. And as you can see in this view here, there's a significant blood supply there. The kidneys will then form urine, and it will travel down the ureters to the bladder. The bladder will then store the urine, and it will be released through the urethra during a micturition event. And micturition is just fancy speak for having a bladder emptying event. So that's a good word to throw around to your friends. There's micturition. If we look inside the kidney, we find the filtering units scattered around the outsides, and these are labeled here as renal pyramids, and then multiple renal pyramids comprise perhaps a renal medulla. But the point is that the filtering occurs towards the outside half of the kidney, and then on the inside you see what's labeled as the major calyx. And this is where the urine is going to be sent to once it's filtered out here in the filtering units. And then it'll come down here to the renal pelvis. And by the time it gets to the renal pelvis, it's actually finished product urine. So there's a lot of filtering and reabsorbing and everything going on out here in the renal medulla region. And then again, it dumps the urine into the calyces and then down to the renal pelvis, where it will empty into the ureter and go on down to the bladder. If we want to talk about the blood supply that the kidneys have, if their job is to filter blood, then it would make sense they would have a tremendous blood supply. So we can see the renal artery coming in here is a pretty good size artery, and then it's going to run out to the outside reaches of the kidney out in the renal cortex. And then in the cortex and in the pyramids is where the filtration will actually take place. So let's talk briefly about that filtration process. There's going to be a couple of pieces involved in this, and the first one that we've already seen in that fabulous image we started out with is the glomerulus. And that's where the first part of the filtration process occurs. After that part is done, then that stuff that's been filtered out of blood will go into the proximal convoluted tubule. Remember from our terminologies that proximal means closer to the point of origin. In this case, closer to the point of where that fluid came out of the blood. Then from the proximal convoluted tubule, it will go into the nephron loop. And in the olden days, this was referred to as the loop of Henle. So if you hear about loop of Henle or you hear about nephron loop, it's the same thing. But the nephron loop has two components to it. The descending limb comes straight out of the proximal convoluted tubule, and then the ascending limb comes back up and ends at the distal convoluted tubule. The distal convoluted tubule will then go to the collecting duct, and in the collecting duct is where we do the final alterations to that product before we call it finished product urine and send it into the calyces and the renal pelvis. So multiple components in this tubing here, and as we'll see here in a few minutes, each one of those components carrying out a specific function. If we were to look at a slice through a glomerulus under a microscope, it might look like what we see here in the middle, this little ball of cells there. And that's actually a large tangled mass of capillaries. And we can't really tell that so well in this view. But here in a little bit, we'll look at some drawings of that, and it will be much clearer as to exactly what's going on there. Before we go any further, I want to mention that there are two different kinds of nephrons. And a nephron is an overall filtering unit of the kidney, or a filtering component, consisting of the glomerulus, the proximal convoluted tubule, the nephron loop, the distal convoluted tubule, and the collecting duct. So all those pieces together in one is called a nephron. And there are millions of nephrons in the kidneys, all of them, again, working to produce urine. But the two different types here are cortical nephrons and juxtamedullary nephrons. And the difference, as you can see here, the cortical nephron here on the left has a relatively short nephron loop, but has significant convoluted tubules. A juxtamedullary nephron doesn't have quite as much in the way of convoluted tubules, but it has a very long nephron loop here. So really the difference is only about probably 15% or so of the total nephron count in the kidneys are juxtamedullary nephrons. But that number sort of belies its importance. Juxtamedullary nephrons are very important because they are capable of forming or greatly regulating urine output in terms of, is it very concentrated urine or is it very dilute urine? So the ability to really regulate fluid balance and concentrated or dilute urine is significant here in the juxtamedullary nephron because of that very long nephron loop. And we'll get to exactly what's happening in those pieces of the nephron loop a little bit later here, and that will hopefully start making more sense. So most of the nephrons are cortical nephrons, and they can also produce urine, but they don't do as good of a job at making concentrated urine. So the juxtamedullary nephron is a specialist at making concentrated urine because of this very long nephron loop. Here's a nice little image of what it might look like inside a kidney. And we've got all these glomeruli scattered throughout there, and you can see in this relatively small space quite a few of those there. And then they would then have their proximal convoluted tubule, nephron loop, distal convoluted tubule coming off of that. But this view just shows us the relatively tight spacing of the glomeruli scattered throughout the renal cortex. So here's the first piece of the actual filtration process. So here's the glomerulus, and so we can see we have an arteriole coming in, and then glomerular capillaries that come off of that. So this particular arteriole here brings in blood, which immediately splits out through all these glomerular capillaries, and they're basically loops that loop from the incoming or afferent arteriole, loop around through the glomerulus, and then come back out into the efferent or outgoing arteriole. And when it comes out of this outgoing arteriole here, it is thought to be, hopefully, relatively clean blood. But what we immediately notice here is that these capillaries are covered with these really alien-looking structures here. So those are going to filter. And they're going to filter, well, here's a closer view, through the filtration slits. Basically, if something is small enough to go through the pores of these capillaries, and these are fenestrated capillaries, so they're relatively porous, relatively leaky capillaries. So if that stuff is small enough to go through the fenestrations and get through the filtration slits, then it goes through. It's taken out of the blood. If it's not small enough to squeeze through those filtering units, it stays in the capillary and goes back out then as somewhat cleaned blood. But obviously, lots of things are going to be able to go through those fenestrations and through those filtration slits that don't need to. All that 47 gallons a day can go through there. So this is where the reclaiming of things go, because this was a pressure-driven system based on size. So if it was a high enough pressure and the size would fit, it came out of the blood, and then whatever couldn't go out based on pressure and size stayed in the blood. If we look at a very fabulous microscopic view of those filtration slits, it starts to look like they're pretty tight, and they are a relatively tight filter, but again, lots and lots of stuff goes through there that doesn't need to necessarily. So the kidney is basically a series of progressively more fine-tuned filtering processes, and this first step in the glomerulus is a very rough and unrefined filtration. And I've said it was a pressure-driven system, so let's look at this pressure here. Hydrostatic pressure, or HP, in this case, let's say, is 55 millimeters. So basically, that's the blood pressure. There is a resistance to that pressure of fluid already in the glomerulus, and let's say here it's the hydrostatic pressure, HPCS, is the resistance of the fluid already in the glomerular capsule, and OP is going to be osmotic pressure. So that's the salt concentration. And so there's a combined resistance there. So whatever the ratio of HPGC is to OP and HPCS is going to determine the net filtration pressure. So how much pressure is there to push things out of the blood? And as long as the incoming, the HPGC, is greater than the osmotic pressure plus the HPCS pressure, then there will be filtration in that glomerulus. There will be things come out of the blood. In this particular case, our incoming pressure of 55, our resistance pressure of 45, and so we have a net filtration pressure of 10. And the greater that filtration pressure, the more fluid and other things will come out of the blood. The less that pressure is, the less stuff will come out of the blood. And this starts to explain to some degree why some people retain fluid when they consume a salty meal. If you've had a lot of salt in your diet, that means that the osmotic pressure, the OP, is going to be greater because there's a greater salt concentration here, and that accumulates more fluid in the, basically if OP increases, then HPCS increases, and that then makes a lesser net filtration pressure to work with, which means more fluid will stay in the blood and go back into circulation rather than being taken out. So we're assuming here that our incoming pressure is greater than the resistance pressure, and so a amount of fluid that will equal the 10 millimeters of pressure will come into the glomerular capsule. So that was step one, pressure and size. Then we get to the proximal convoluted tubule. So if we look over here in our little drawing, here was the glomerulus right here. And then we get into the proximal convoluted tubule. And what it's going to do is it's going to reabsorb some things. So again, if it was big enough, or rather if it was small enough, and there was enough pressure, it would come out of the blood. So some things we want to reabsorb back into the system. In this case, the proximal convoluted tubule will reabsorb sodium. It should also reabsorb nutrients. So sugar, proteins, vitamins, things like that should be reabsorbed by the proximal convoluted tubule. And this is where you see things happen negatively with diabetes. With diabetes, you have abnormally high sugar levels in the blood, and then the proximal convoluted tubule is overwhelmed. And it can only absorb so much sugar, and if there's too much in the blood, too much coming into this filtrate, into this potential urine, then the proximal convoluted tubule just simply can't keep up with it. And then you would find sugar remaining in the urine because it wasn't pulled out by the proximal tube. We also see chlorine, magnesium, calcium, lots of other things absorbed there. Water, a little bit of water reabsorbed there. Lipid-soluble stuff can be absorbed there, and urea can be reabsorbed there as well. So lots of reabsorption happening there of things that came out from the glomerulus that, again, we didn't really want to get rid of. If we move to the nephron loop, we have the descending limb and the ascending limb. The descending limb is going to be primarily focused on reabsorbing water. The ascending limb is going to be primarily focused on absorbing sodium, chlorine, calcium, magnesium, potassium, those ions, those electrolyte substances. And so we could say the descending limb focuses on regulating water at this point, and the ascending limb focuses on regulating electrolytes at this point. When we move into the distal convoluted tubule, it's also going to reabsorb, and it's going to focus on more salt, so more sodium and more chlorine, and we'll also focus a little bit on reabsorbing calcium. Then we get into the collecting duct, and the collecting duct sort of makes some final decisions. We'll look at the concentrations of urine here in a minute, but the collecting duct can reabsorb certain things. It can reabsorb sodium and chlorine and water and urea, or it can dump those back into the system. So we go through a number of steps that in a little bit when we look at it will seem quite contradictory, and I'll try to explain what's really going on there. But the collecting duct is the last chance to reabsorb anything that we didn't get out from any of our reabsorption points so far. And whatever goes through the collecting duct and is not reabsorbed will be excreted in urine. So the collecting duct is the last chance to get this fine-tuned just right. So let's re-examine that briefly here. We had the glomerulus, and then we started reabsorbing stuff in the proximal convoluted tubule. And at this point, we might say that we're going to call everything that was taken out of the blood at the glomerulus, we're going to call that filtrate. So about 65% of the filtrate that was produced by the glomerulus will be reabsorbed in the proximal convoluted tubule. So over half of everything that was filtered by the glomerulus is removed right off the bat. And again, you're seeing a little bit of everything: water, salt, sugar, all kinds of other things there. Then we go into the descending loop of the nephron loop, or the descending limb, we should say. We take out water. In the ascending limb, we take out sodium and chlorine and potassium and things like that. We might do a little bit of manipulation with urea as well. Then we get into the distal convoluted tubule. We've got all those things being reabsorbed there. And then in the collecting duct, we'll finish it up. So let's look at some numbers here. If the filtrate, that fluid removed by the glomerulus, has a concentration, let's say, of 300, it enters the proximal convoluted tubule and lots of stuff is taken out, but we don't really see the concentration changed because the proximal convoluted tubule was taking out both water and the salts and the sugars and things like that. So everything roughly was reabsorbed in equal quantities here, and so we didn't really see the concentration change. As we enter the descending limb of the nephron loop here, we start seeing our concentration go from 300 all the way up to 1200. And so all along the way, we're taking out water. As we go up the ascending loop, we can see our concentration go from 1200, 700, 400, 200, 100. So we become the most dilute towards the end of this filtration process. And this seems a little bit counterproductive. Why do we go from a low concentration to a high concentration, back to a low concentration again, to an even lower concentration than we had before? And the answer is, and I hope this makes sense to you, is that, remember, 65% of everything was reabsorbed by the proximal convoluted tubule. So as we go, yes, the concentration is changing, but overall the urine is becoming more concentrated because it is becoming a lesser volume. That 47 gallons, by the time we get to the end of the ascending loop here, we might be down to only a couple of gallons left from that. So we've greatly reduced the overall volume. And while we do get the concentration back down to a relatively dilute concentration, our volume has been reduced significantly. After that fluid leaves the distal convoluted tubule, it goes again into the collection duct, where we'll see the final adjustment of concentration. So let's look at this graphic here and explore this concept. If you're overhydrated, so you've consumed more liquid than you needed to, antidiuretic hormone levels will be quite low. So antidiuretic hormone really has an effect on the collecting duct. It doesn't do that much differential on the nephron loop or the glomerulus, but it really impacts what happens in the collecting duct. And remember, that was the last chance to modify things. So we go through the process. We get more concentrated in the nephron loop, then we get unconcentrated. The distal collecting duct sends a urine with a concentration of 100 into the collecting duct. And you'll notice in both cases, overhydrated and dehydrated, that's what happens. The difference becomes what happens to it when it's in the collecting duct. So if you're overhydrated, meaning there's very little antidiuretic hormone present, what's going to happen is the water-absorbing proteins, the aquaporins, in the collecting duct are going to close. And so that means that that very dilute urine that came out of the distal convoluted tubule stays dilute. And you're dumping, in this case, lots of water relative to the other stuff that's dissolved in that fluid. So to get rid of lots of urine, you're going to reduce the reabsorption of water from the collecting duct and just let that dilute stuff flush on through. So this is going to produce lots of urine. And if you're drinking plenty of water, you're producing lots of urine, and it's a very pale color. And that pale color really tells you that it's dilute stuff. If we're dehydrated, so we don't have enough water, that means antidiuretic hormone levels are going to be higher. They're going to be more concentrated in the system. So again, the nephron loop does its thing. Distal convoluted tubule provides 100 concentration of urine, but look at what happens in the collecting duct. Here we have the number of aquaporins increase, and we have a greater activation of them. So think of them as channels that are wide open. And what happens here is they actively pump water out of the urine here all the way down the collecting duct. So we start out at a concentration of 100, and we could get all the way up to a concentration of 1200 at the end of the collecting duct, but that's going to be a small volume. So in our overhydrated state, we produced a large volume of dilute urine. In a dehydrated state, we produce a small volume of concentrated urine, and that's all determined by the number of aquaporins activated in the collecting duct. And that's pretty much based on, do you have enough fluid to dilute the antidiuretic hormone, or is it pretty concentrated? So again, we've changed these concentrations back and forth and back and forth. But every time we do something to it, we're reducing the total volume. So that by the time it's all said and done, we go from the 47 gallons that came out in the glomerulus to the roughly 1.5 quarts that actually goes to the bladder every day. There are a number of things that are not normally found in urine. So you hope to not see these, and if you do see them, that tells you that you have some sort of problem. So let's take a quick look at that. You don't want to see glucose, sugar in the urine. So again, if you see sugar, probably looking at diabetes. We shouldn't see protein, because protein should have been absorbed by the proximal convoluted tubule as well. So if you're seeing a lot of protein in the urine, that can indicate a number of things, perhaps something as simple as very high blood pressure. Remember in the glomerulus where the protein was coming out, that was a pressure situation. So if you have abnormally high blood pressure, that will push an abnormally high number of proteins out of the blood into the filtrate at that point. And again, the proximal convoluted tubule can only filter out so much. So it simply would be overwhelmed by the high blood pressure. You can read here as well if there's problems with the glomerulus. If there's heart failure, if there's some sort of kidney disease coming on, that can also be exhibited in the form of protein in the urine as well. So regardless, there's a problem. Ketones. If you are seeing ketones in the urine, you're looking at some sort of metabolic problem, probably either, again, diabetes or some degree of starvation. And this is what you see often with the keto diet. And the keto diet folks are very proud of inducing ketoacidosis in the body. And really what they're doing is they're putting so many ketones in the form of acid in the blood that when it gets filtered, that high amount of acids actually comes out to some degree in the urine as well. So that's just proof that they have induced a metabolic acidosis in their body in the form of starvation, really, because a big part of the keto diet is fasting. So when you're fasting, you're engaging in a temporary starvation mechanism. And so that then expresses as ketone bodies. That's also going to give you ketoacidosis breath or keto breath. And that also expresses in the breath as a very unpleasant smell, again, as a result of this starvation kind of scenario. And even if you're not fasting, if you're losing weight rapidly, and that's usually what happens with the diabetes to produce the ketones, is the rapid weight loss or the rapid unregulated metabolism of fats and other things causes that to occur. So either way there, we don't want to see that either. Hemoglobin. If we see hemoglobin in the urine, that means we have blood in the urine. And that's a problem for a variety of different reasons as well. Bile pigments, if they're in the blood, or rather if they're in the urine, that means we have some sort of liver problem or gallbladder problem. And that should probably be looked at right away, because if it's an obstruction of the bile duct, that can actually result in self-digestion of the liver, which would be quite fatal. And that can happen pretty quickly. So I would think bile pigment in urine would be something that needs to be checked out right away. And that will probably often exhibit as brown colored urine, or at least could exhibit as brown colored urine. So brown urine for no reason, take a good look at that. Erythrocytes, so red blood cells. Again, we're looking at blood in the urine, and again, there shouldn't be. So that means somewhere in there is an infection. There's been some sort of trauma. Maybe there's kidney stones that are basically scratching their way through the system and causing bleeding, or it might be cancer. So either way, chronic red or pink urine is usually what we could see. Or you could see brown urine if it was very early in the system as well. If that's something that's happening for more than a day or so at a time, probably should get checked out. If there's leukocytes, or white blood cells present in the urine to a noticeable level in the form of pus usually, that indicates a urinary tract infection of some sort. And that could be just a bacterial UTI, or it could be the expression of an STD. Can also cause pus to occur in the urinary system. So all those things there, we really don't want to see those in the urine, because all these filtration steps along the way, if they're working properly, should have prevented all of that. Hopefully you learned a lot about how kidneys work here, and we really could probably spend a couple of weeks really talking about it if we wanted to, getting in great detail about this hormone and that hormone and some other complicated things. But in the simplest form, kidneys work on blood pressure in the glomerulus. Then we get into concentrations of salt and water and other dissolved things as we work our way through the rest of the system. And while it is inefficient, it works. If you drink plenty of water, that will help to keep this stuff flushed out as well. So one thing you can do is to know if you're having enough water in your diet is your urine should be a very pale yellow color. And if it's not, then that means you need to drink more water because the stuff in the urine is so concentrated. So really you want to be able to produce relatively dilute urine on a regular basis, and that means your kidneys are keeping flushed out. If you don't, that puts you at greater risk of developing kidney stones. And if you've ever had a kidney stone before, you will know it is not something that you ever want to have again. So drink lots of water, and that will help the kidneys keep flushed out. Thanks. Have a great day.